All right, good afternoon and welcome to the Department of Medicine Grand Rounds, and apologies for the 2 minutes technical problem. Big surprise with Teams, that we're having technical problems, but it's now working fantastic. I'm very pleased today to introduce Dr. Matthew Collins as our speaker for Grand Rounds. Dr. Collins completed his medical education at the University College Cork in Ireland, followed by, just want to make sure I don't know why I'm getting these things, okay. Followed by internal medicine residency at Bay State Medical Center in UMass in the US. Luckily for us that Matthew came back to Canada, where he completed his gastroenterology training, residency training with us at McMaster, followed by advanced clinical hepatology training at UFT, at Toronto Center for Liver Disease, and following that completed 4 months work in training in acute hepatology. Then again, lucky for Hamilton, Matthew returned to Hamilton in November 2021 to practice general hepatology with liver care, and we were able to bring him back to McMaster in July 2023, where he joined the Department of Medicine Division of Gastroenterology as an assistant professor, clinician educator track. He's currently the Hamilton General Coordinator for Gastroenterology Training, and he was awarded the Clinical Teaching Award by GI Resident in June 2024. Congratulations. His clinical focus includes the treatment of a broad spectrum of liver diseases, with a particular emphasis on steatotic liver disease, reflecting the increasing prevalence, and at no surprise, he's going to be speaking to us today about MASLD, a comprehensive approach to modern management in 2024, a topic that's key not only to hepatologists and gastroenterologists, but all of us practicing medicine, especially general internists and others. So Matthew, without further ado, I'll give you the Teams screen.
All right. And so first, I'd like to show this as a land acknowledgement slide, and to state that we are privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. And so thank you, Dr. Azam, for the kind introduction. It's truly an honor to present at Medical Grand Rounds McMaster. I'm grateful for the opportunity, and it's a bit surreal. I grew up in Hamilton, went away for a few years in training, and now to come back to where my life all started at McMaster University Medical Center, actually, where I was born. So thank you for the kind introduction. This slide is just kind of a picture of my background that Dr. Azam already alluded to. Grew up in Dundas and went to Western for my pre-medical education, followed by medical school in Ireland in Cork, then to Bay State in Massachusetts, then back to McMaster for my gastroenterology training, and then just over a year at the TCLD in Toronto. And then I came back and started my practice with the liver care clinic here in Hamilton, and I've joined the McMaster faculty, as Dr. Azam mentioned. And so when I was first invited to deliver medical grand rounds, the choice of topic was clear: metabolic dysfunction associated steatotic liver disease, or MASLD, or MASLD to make it easier, which was formerly known as fatty liver disease, or NAFLD. This condition is currently at the forefront of hepatology research, with its significance extending far beyond just the liver. MASLD's intricate connections to systemic health and its relevance across multiple specialties within internal medicine makes it an ideal subject for today's diverse audience. The focus of our discussion will be on the current management strategies for MASLD, a topic that has significant advancements in recent years. And my goal is to provide insights that each of you, regardless of your specific field, can apply to enhance patient care in your everyday practice. And so I have no relevant financial or non-financial relationships to disclose that could be perceived as influencing the content of this presentation. All information presented today is based on peer-reviewed literature, clinical guidelines, and my professional experience without any conflicts of interest. These are the candidate roles I'll be addressing today. And so listed here are the learning objectives for today's presentation, which you all likely received in the email last week regarding this talk. By the end of the presentation, you'll understand the fundamentals of MASLD, including its definition, pathophysiology, and epidemiology. We'll cover evidence-based management strategies, focusing on weight loss strategies, dietary interventions, supplements, alcohol recommendations, exercise goals. And additionally, we'll explore crossover treatments for related metabolic conditions and disclose or discuss emerging therapies for MASLD. To lay the foundation for our discussion today, let's begin by clearly defining steatotic liver disease. At its core, hepatic steatosis is defined as the accumulation of fat in hepatocytes. This can be demonstrated through histology, imaging, or biomarkers. Steatohepatitis, on the other hand, has traditionally been a histologic diagnosis. It's characterized by the presence of greater than or equal to 5% hepatic steatosis, inflammation, and hepatocyte ballooning with or without fibrosis. It's crucial to note that at present, steatohepatitis can only be definitively diagnosed through liver biopsy. Neither imaging nor blood work can provide a conclusive diagnosis. And it's important to remember that elevated liver enzymes does not necessarily equate to NASH, MASH, or steatohepatitis, whatever the definition you want to use. The field of biomarkers is a significant area of research within the MASLD space. While numerous biomarkers for steatosis are being studied, most are still in the research phase and not yet fully validated for routine clinical use. However, several biomarkers have been validated for detecting advanced fibrosis, though this is not the scope of our current discussion today. Okay. So the concept of fatty liver disease has evolved significantly over the past 2 centuries. And in 1825, the term foie gras first appeared in French medical literature, with Thomas Addison describing fatty liver disease in 1836. Throughout the 19th century, pathologists like Rokitansky recognized the link between hepatic fat accumulation and fibrosis. The 20th century saw major advancements in our understanding. Steatohepatitis was first described in 1962, but it wasn't until 1980 when Ludwig coined the term non-alcoholic steatohepatitis, or NASH. Initially, this was thought to be benign, but NASH was later recognized as a serious condition by the 1990s. The term NAFLD, or MASLD, emerged in around 1986, becoming widely used by 2002 to distinguish metabolic-related liver disorders from alcohol-induced ones. In June of 2023, a significant shift occurred in the field of hepatology with the formal announcement of the term MASLD, or MASLD, which stands for metabolic dysfunction-associated steatotic liver disease. Just rolls off the tongue, really. This change was the result of a rigorous Delphi panel process where a supermajority agreed that a term referencing the underlying disease pathophysiology was preferable to NAFLD. Consensus was reached for an affirmative, non-exclusionary, non-stigmatizing description of the condition. This approach not only reduces stigma for patients, but also acknowledges the multiple diverse drivers of the disease. It's important to note that studies have demonstrated a greater than 99% overlap between patients previously identified as having NAFLD and those meeting criteria for the new MASLD. This high concordance ensures continuity in patient care and research. The spectrum of steatotic liver disease, ranging from simple steatosis to steatohepatitis and cirrhosis, remains applicable under the new terminology. One of the most significant changes in this new nomenclature is the integration of MASLD and alcohol-related liver disease. Previously, alcohol use precluded a diagnosis of NAFLD. Now, under the umbrella term steatotic liver disease, cases can be further differentiated based on the underlying etiology, which we'll explore in more detail on the next slide. Okay. So the figure on this slide illustrates the subclassification of steatotic liver disease and introduces two new terms. This MASLD, which you may see in some of my notes, stands for metabolic dysfunction associated and alcohol-related liver disease in conjunction, as well as the term cryptogenic steatotic liver disease, where an etiology cannot be determined. In the top right corner of the screen, you'll find the criteria for diagnosing MASLD, and you'll see that there's significant crossover with the criteria for metabolic syndrome. This new classification system allows for a more precise diagnosis and potentially more tailored treatment strategies, acknowledging the multifactorial nature of steatotic liver disease. Now that we've established the proper definition for steatotic liver disease, let's examine its epidemiology. Historically, the global prevalence of MASLD or NAFLD was estimated at approximately 25%. In Canada, it was estimated that about 7.8 million people were living with NAFLD in 2019. However, recent data suggests that over 30% of the population now has MASLD, likely due to increases in the rates of obesity, metabolic disease, and sedentary behaviors, particularly during and after the COVID-19 pandemic. MASLD prevalence varies across populations, with higher prevalence rates seen in the Asian Pacific, Latin America, and the Middle East, and low rates seen in Africa. There's also increased prevalence rates in certain disease populations, particularly those with metabolic disorders such as diabetes. A Canadian study published in 2020 projected a 20% increase in MASLD prevalence from 7.8 million in 2019 to over 9 million by 2030. The graph on the bottom right illustrates the expected increase in MASLD prevalence, along with an even more significant rise in steatohepatitis, associated liver fibrosis stages, and complications from advanced liver disease. MASLD is currently the most common liver disease in developed countries and is expected to become the leading cause for liver transplant in the next decade or so. Given this projected growth, it's crucial that we increase our general awareness of MASLD, start to identify at-risk individuals to make a timely diagnosis, and initiate early intervention before the disease becomes too advanced. And so these steps will be essential to reduce disease burden and prevent overburdening of our already overwhelmed healthcare system here in Ontario and Canada. Despite the growing burden of MASLD, a recent CanNASH survey revealed a concerning knowledge gap amongst Canadian healthcare providers. The survey found that a significant proportion of physicians and nurses managing patients with liver disease are not sufficiently familiar with NAFLD. 58% of primary care physicians, 20% of specialists, and 39% of nurses reported being only somewhat familiar or even unfamiliar with the disease. So these results further underscore the urgent need for enhanced provider education. In terms of pathogenesis, MASLD is considered to be the hepatic manifestation of metabolic syndrome. The hallmark of MASLD is the accumulation of fatty acids in hepatocytes resulting from complex interactions among genetics, comorbidities, the microbiome, as well as lifestyle factors. These pathways vary in their impact across different patients, as demonstrated by the figure on the top right corner of the screen. The buildup of free fatty acids in the liver causes hepatocyte stress and inflammation, which leads to activation of stellate cells, which leads to progressive fibrosis. A nearly universal contributing factor is insulin resistance, which we'll explore further in this presentation. MASLD is generally a slowly progressing disease. Only about 20% of patients with NAFLD progress to NASH or MASH, and roughly a quarter of those develop progressive fibrosis, and a fraction of those will go on to develop cirrhosis. So to keep things simple, I like to use a 20-25-30 rule. So 20% of patients with NAFLD will develop NASH, 25% of those develop progressive fibrosis, and 30% of those develop cirrhosis. In the past, it was thought that only patients with NASH could progress to cirrhosis. However, it is now understood that a small proportion of patients with NAFLD or MASLD can progress to cirrhosis without showing definite histologic evidence of steatohepatitis or NASH. In regards to prognosis, it's the extent of underlying hepatic fibrosis and not steatosis or steatohepatitis that is most important in predicting prognosis and liver-related morbidity and mortality. Patients with MASLD have an approximately 65% increased risk of cardiovascular disease and are more likely to die from this compared to a liver disease than those without advanced hepatic fibrosis. The management of MASLD can be broken down into three main categories. We have lifestyle interventions, which is the foundation, medical risk management, and specific pharmacotherapy, which is a hot topic in research with many targets identified, some of which are illustrated in the figure on the bottom right of the screen. Let's go through some of the lifestyle interventions in more detail and discuss some of the evidence. So weight is perhaps the most important variable in patients with MASLD. Weight gain by itself, even only a modest 3 to 5 kilograms, predicts the development of MASLD, regardless of baseline BMI. Numerous studies have linked the degree of weight loss to improvements in steatosis, steatohepatitis, and fibrosis. And there is a clear dose-response association. There is consensus that gradual weight reduction achieved by caloric restriction, with or without increased physical activity, leads to an improvement in serum liver enzymes, liver fat, and the degree of hepatic inflammation and fibrosis. As shown in this figure on the slide, if we want to target ballooning inflammation, patients should lose about 5% of their body weight. But if we want to target fibrosis regression or MASH resolution, we want to target 7 to 10% weight loss, and I generally recommend slow weight loss over a period of 6 months. Rapid and drastic weight loss can be detrimental and even harmful, and it's often not maintained. The right column in this figure demonstrates the difficulties with sustaining higher levels of weight loss, which is why it's important to suggest lifestyle interventions that patients can adhere to for the long term. Let's talk about some specific diets. There are so many different diets available today, as illustrated on this slide, and it can be overwhelming for patients, kind of like the slide actually, when they try to decide which one they're going to follow. Weight loss diets work by three main mechanisms. One, macronutrient manipulation, two, timing, and then three would be food group restriction. The chart on the bottom of the slide lists some of the popular diets and the relative proportion of macronutrients and different restrictions. All of these diets have several components that support weight loss. These include adherence to a negative energy balance, because that is how patients will ultimately lose weight, and a focus on high quality foods. Most of these popular diets do not have high quality evidence of benefit in fatty liver disease. The Mediterranean diet is a relatively balanced diet and currently has the strongest data in multiple different disease processes. At the end of the day, the best diet is going to be one that a patient can adhere to and sustain. There may be a role for use of more restrictive diets, at least in the short term, as we will discuss shortly. As previously mentioned, the Mediterranean diet is one of the most well-studied diets out there. It is recommended for many different diseases, including cardiovascular disease and diabetes. It is classified as a reduced carbohydrate, moderate fat diet with predominantly monosaturated and omega fatty acids. Compared with a typical Western diet, the Mediterranean diet comprises a lot less meat and dairy. There's actually very little red meat and saturated fat, and more monosaturated fats like olive oil. The figure on the right of the slide gives a breakdown of different foods that make up the diet. As you can see, in general, it's high in lean meats, fish, nuts, fruits, legumes, vegetables, and olive oil. Of note, moderate wine consumption is often listed in these diets when patients look online. However, we'll discuss, the alcohol recommendations on a later slide. So here's a 6-week crossover study in non-diabetic patients who had biopsy-proven MASLD or NAFLD. There were 12 patients in total, so a small study. and they were placed on either the Mediterranean diet or a low-fat but high-carbohydrate diet. The results of this small study were that there was a reduction in hepatic fat for subjects who were on the Mediterranean diet as compared with the low-fat but high-carbohydrate diet. In addition, insulin levels were significantly lower in subjects who consumed the Mediterranean diet over the low-fat but high-carbohydrate diet. This very small study had a nice crossover design where the same 12 patients ate both diets for 6 weeks with a washout period in between. And then intrahepatic lipids were compared in the same individuals. Liver fat went down when they were on the Mediterranean diet, more so than when they were on the low-fat diet, even though weight loss was similar because the low-fat diet was also hypocaloric. Intermittent fasting is a diet that focuses on what you eat rather than, when you eat rather than what you eat. It's based on the concept that eating and snacking regularly utilizes predominantly glycogen and calories from food, especially with decreased activity, rather than fat stores. Intermittent fasting works by prolonging the period when your body has burnt through the calories consumed during your last meal and begins burning your own fat. The figures on this slide are from a recent international meta-analysis of male and female patients over the age of 18 with MASLD. Different protocols were used for intermittent fasting, ranging from religious fasting during Ramadan, which is typically 15 to 16 hours, to every other day fasting of 18 to 22 hours with caloric restriction. In one study, with 16 hours of daily restricted fasting. Fasting was compared to control groups, and meta-analysis demonstrated significant differences in body weight, BMI, and aminotransferases. However, these studies were short and long-term data is still required, but the initial studies look promising. Of note, longer periods without food, such as 24 to 72 hours fasting, are not necessarily better for you and may actually be dangerous. So I don't often encourage very extreme or intense fasting periods. This slide outlines a study from 2014 that compared a hypercaloric diet with structured meals versus snacking. So it measured intrahepatic triglyceride content, abdominal fat, and insulin sensitivity before and after a 6-week dietary intervention. The study found that participants who consumed food between meals or snacked had increased intrahepatic triglycerides in abdominal fat compared to those that consumed their diet during scheduled set meals, independent of calorie content and body weight gain. So this study suggests that snacking, a common feature in our Western diet, independently contributes to hepatic steatosis and obesity. And so this is something that I often counsel my patients on, is the impact that their snacking has on their liver and their weight. The ketogenic diet, or keto diet, is something that a lot of patients ask me about. As previously noted, it's classified as a very low carbohydrate diet. It's been demonstrated to be very effective at causing weight loss. However, long-term studies are still required to determine the effect of maintaining such an extreme diet. The European Guideline on Obesity Management for Low-Carb Diet only recommends short-term use, and this is typically done under medical surveillance, and then it's transitioned to a more sustainable diet for weight maintenance for the long term. The common belief that increasing dietary fat intake invariably leads to fatty liver and prevents fat mass loss has been recently proven wrong by an elegant experiment showing that normal caloric, high-fat ketogenic diet inhibits de novo lipogenesis and induces fatty acid oxidation, leading to weight loss and reduced hepatic fat content. It is hypothesized that ketones affect inflammation as well as metabolic disease. Another thing that we must consider in our MASLD patient population is that they are much more likely to have morbidity and mortality from cardiovascular disease than they are to suffer liver-related death or serious liver events, as I previously noted. Therefore, any diet that we've recommended to patients with MASLD must also be heart healthy. A meta-analysis of randomized controlled trials comparing low carbohydrate and low fat diets in overweight and obese subjects for approximately 1 year found that each diet had different benefits. Low carbohydrate diets were superior for improving the metabolic syndrome components that are very typical in our patients with MASLD, which include improving weight loss, raising HDL, lowering triglycerides, and lowering blood pressure. The low-fat diets were superior for lowering LDL and total cholesterol. Importantly, ASCVD risk was reduced by both diets, but more by low-carbohydrate diets. And a low-carbohydrate diet, even if it's higher in fat, is not going to raise cardiac risk in our MASLD patients. Another consideration is malnutrition and sarcopenia. Although MASLD is strongly associated with an elevated BMI, patients may present with malnutrition or sarcopenia, and this should be screened for, as both are predictors of morbidity and mortality. So in summary, the best diet is one that can be sustained. Healthy eating rather than dieting should be encouraged due to the stigma associated with the term dieting. In general, diet should be hypocaloric with elimination of sugar-sweetened beverages and sweets as much as possible. The Mediterranean diet is currently the best studied diet and is recommended in multiple guidelines. There's still limited evidence for other diets, but this may change in the future. Finally, it's important to consider each patient's comorbidities when suggesting a diet to ensure overall health is considered and managed. Now let's talk about some supplements. So the antioxidant nutrient or vitamin E has been associated with NASH or MASH since the well-known Pivens trial back in 2010. Results from the trial are shown on this slide. So in this study, investigators examined the use of pioglitazone and vitamin E in non-diabetic, non-cirrhotic patients with biopsy-proven NASH. So it's a very specific population. As shown, patients who received vitamin E had improvements in their histologic features of NASH and a trend toward improvement in fibrosis. Another retrospective study of vitamin E in patients with NASH and advanced fibrosis found that vitamin E users had higher adjusted transplant-free survival and lower rates of hepatic decompensation. Studies have reported side effects from high-dose vitamin E therapy, including prostate cancer, hemorrhagic stroke, worsening heart disease, and increased overall mortality. However, data has been quite variable, and there are other studies that report favorable effects on other cancers as well as macular degeneration. Next, let's look at everybody's favorite supplement, if you will, coffee. Coffee is rich in caffeine, antioxidants, and polyphenols, and it's thought to exert its effect on the liver by reducing hepatic fat, oxidative stress, and inflammation. A 2013 meta-analysis noted that coffee is associated with decreased steatohepatitis, fibrosis progression, lower cirrhosis mortality rate, and lower rate of HCC. Coffee is also associated with a decreased risk for other comorbidities such as metabolic syndrome, diabetes, symptomatic gallstones, cardiovascular disease, Parkinson's, and overall mortality. As much as it kills me to say, all types of coffee have been studied, including decaf and instant coffee, if you like that. However, the strongest effect is with filtered ground coffee. The magic number is 3 cups per day. And I always love telling my patients that 3 cups a day keeps the fat away. Kind of very catchy. But if they're having intolerance to caffeine with palpitations, insomnia, or anxiety, that needs to be considered. And it's not a deal breaker if they can't have coffee. So the liver is involved in the transport and storage of micronutrients. And many patients with MASLD have low levels of micronutrients in their blood, including zinc, copper, vitamin A, vitamin D, and vitamin E. While we don't understand the specific mechanisms that contribute to these low levels, we do know that this has been associated with MASLD severity. In theory, therefore, vitamin supplementation may benefit MASLD patients through their antioxidant, antifibrotic, immune, and lipoprotective effects. But with the exception of vitamin E, no vitamins are currently recommended to treat MASLD at this time. Patients with obesity and MASLD are at risk of vitamin D deficiency. The Endocrine Society guidelines recommend screening for vitamin D deficiency if your BMI is greater than or equal to 30 and treating vitamin D levels less than 20. It has been suggested that vitamin D supplementation might improve lipid profile, insulin sensitivity, and inflammatory mediators. Studies noted that low serum vitamin D concentrations correlates with the presence and severity of liver steatosis and neck inflammation over the course of steatohepatitis. However, again, more evidence is still required for this vitamin. Living in Canada, we get less sunlight than other parts of the world, especially in the long winters. So many of us are vitamin D deficient. Thus, it may be worth empirically taking vitamin D at least during winter months to prevent deficiency. In patients with just MASLD, there was a trend towards improvement in liver fat in those treated with 3 to 4 grams of omega-3 fatty acids, but the evidence is not convincing and the optimal dose remains somewhat unclear. The daily consumption of 300 grams of a probiotic containing yogurt for 8 weeks was reported to improve liver enzymes in patients with MASLD compared to conventional yogurts. However, again, evidence is still limited, and this is not routinely recommended to patients, although the harm in doing so is quite low. Alcohol consumption is something that almost all of my MASLD patients ask me about. Complete abstinence from alcohol with cirrhosis is well accepted. However, alcohol consumption in patients with uncomplicated MASLD is a bit more of a controversial topic. ASLD guidelines from 2018 advise against heavy alcohol consumption. However, relatively recently has been demonstrated that there is a lower threshold for liver injury than previously thought. In addition, there's no real consensus on what moderate to light alcohol consumption is or what a standard drink even is, which is demonstrated on the chart on the top right of the screen. In the past, it was suggested that light alcohol consumption may decrease the risk of cardiac disease, which was supported by some studies which demonstrated a decreased risk of MI. However, these studies also demonstrated increased risk of coronary artery disease, stroke, heart failure, and mortality from cardiovascular disease, which is demonstrated on the bottom right of the screen in those graphs. It also increases the risk of liver disease progression and cancer, including HCC. As a result, I tell my patients that there is no safe level of alcohol consumption that can be recommended, and that abstinence is the ideal target if within their goals of care. If not, I try to get them to consume less than 2 drinks per week per the new low-risk drinking guidelines. So now let's talk about the other part of weight loss, exercise. When assessing a patient's activity levels, it should be broken down into sedentary time and physical activity or exercise, as both have effects on the body. Exercise causes many positive changes both to the liver as well as the rest of the body, as demonstrated by the figure on the top right of the slide. It increases peripheral insulin sensitivity, decreases visceral fat, changes energy balance and circulatory lipids, and also improves cardiovascular and respiratory function. The benefits are seen even in the absence of weight loss, and benefits occur with both aerobic as well as resistance training. However, many of the benefits are lost when exercise habits stop, which is why I always emphasize the importance of consistency with an exercise routine. In regard to sedentary time or inactivity, this behavior is increasing in society, especially during and with the post-COVID-19 pandemic, with a lot of working from home and virtual meetings such as this, I suppose. Sedentary time is also linked with more snacking, which was previously shown to increase hepatic steatosis and an unhealthy diet. It has also been linked with metabolic syndrome, excessive adiposity, and diabetes. Not only is the total duration of sedentary time important for metabolic risk, but also the breaks in sedentary time, independent of the total time spent being sedentary. Increased breaks in sedentary time is beneficial for obesity control and glucose and triglyceride metabolism. So listed on this slide are some exercise recommendations from recent publications. I generally recommend 150 to 250 minutes of moderate to vigorous aerobic exercise per week, done over at least 3 days. As mentioned before, there is benefit from resistance and aerobic exercise, but the benefit from resistance training in isolation isn't great, and so I always recommend that this be done with aerobic or cardiovascular training. And every patient's different. A lot of patients have other comorbidities, arthritis, mobility issues, and so that needs to be taken into account when talking to patients and counseling. I often recommend pool-based or water-based exercises for those with very advanced arthritis, and even things like the QB, where you can sit on your couch and pedal along, can be helpful for a lot of the elderly patients. So managing comorbidities associated with MASLD is crucial for optimizing patient outcomes, as it involves addressing interconnected health issues across multiple systems. A multidisciplinary approach, integrating care from primary providers, endocrinologists, cardiologists, and other specialists, ensures comprehensive treatment plans that target not only liver health, but also cardiovascular, metabolic, and psychological well-being. This coordinated care maximizes the effectiveness of interventions and improves overall patient health. Diabetes is a significant risk factor for MASLD. While MASLD can occur in patients with type 1 diabetes, it is more prevalent in those with type 2 due to shared metabolic risk factors. Even without diabetes, MASLD is associated with insulin resistance and a 2 to 5-fold increased risk of developing diabetes. Diabetes is associated with an increased risk of fibrosis progression and HCC. Many of the anti-hyperglycemics used to treat diabetes have been tested in patients with fatty liver disease and have demonstrated positive results. Despite metformin perhaps being the most commonly used oral medication for diabetes, it does not appear to significantly improve liver histology or fibrosis in MASLD patients. Diabetes medication most commonly linked with MASLD at this time is semaglutide or Ozempic and GLP-1 agonists. They've recently also been popularized for weight loss, and a lot of patients come in asking for this medicine for that purpose. Studies have demonstrated improved insulin sensitivity, satiety, and histologic improvements in steatosis and steatohepatitis with decreased fibrosis progression, in addition to the well-known weight loss. Tirzepatide is a dual GLP-1 and GIP receptor agonist, has some positive results in MASH improvement without worsening fibrosis in phase 2 trials, involving patients with, quote, high-risk MASH, so hepatitis with moderate to advanced fibrosis, and has already established its significant weight loss effects. We are still waiting for more data on hepatic fibrosis, which will surely be presented later this year at the liver meeting in November. PPAR agonists such as pioglitazone have been studied in patients with MASLD and demonstrated a positive effect on steatohepatitis and fibrosis, but are also associated with weight gain, bone mineral disease, and exacerbations of CHF. Thus, I find that they are not used very often these days. SGLT2 inhibitors are beginning to be studied in MASLD, and they have been associated with reduced hepatic steatosis and fibrosis through non-invasive testing, but we still have very little histologic data for these drugs. GLP-1 agonists and PPAR agonists are the only diabetes drugs to improve steatohepatitis. And in Canada, pioglitazone is the only diabetes medication with a listed indication for treating NAFLD. Okay, so hypertension is also part of the metabolic spectrum, and it is an important risk factor for cardiovascular disease. Studies have found high rates of masked hypertension and abnormal nocturnal blood pressures dipping in patients with MASLD, which both represents important risk factors for adverse cardiovascular events. Thus, hypertension screening and management programs in this high-risk population are certainly required. There are some observational data regarding the effects of ACE or ARBs in MASLD in preventing liver-related events, but data is conflicting. This class of medication has many other positive effects for other metabolic diseases, such as diabetes and heart disease. So I typically support its use unless there is hepatic decompensation, particularly with ascites, which these medicines can exacerbate. Statins have a rocky history in relation to liver disease. While there were historic concerns about liver toxicity, recent evidence suggests the risk of serious liver injury from statins is actually very low. Mild asymptomatic elevations in liver enzymes can occur with statin use, but these are often temporary and resolve on their own. Statins appear to be safe for use in patients with pre-existing liver conditions like NAFLD, NASH, and even compensated cirrhosis. And overall, the evidence suggests that for most people, the potential liver protective benefits of statins outweighs the low risk of a liver injury. There's also the added benefit again of in cardiovascular disease and reducing cardiovascular risk. And so I look for any opportunity to support statin use in my patients. So this study by Validol, presented as a poster at the liver meeting last year in November, used the UK Biobank to assess the development of liver disease, HCC, and liver-related mortality in statin users versus non-users who had indication for statin use without a prior diagnosis of liver disease. The results demonstrated a significant reduced risk of developing new liver disease and a lower risk of liver-associated death with statin use when compared to non-users. There's also a lower risk of developing HCC, which has been described in previous studies as well. With the growing prevalence of steatotic liver disease as well as metabolic disease, I think that's important to do anything possible to stop the trend. Results from the study suggest that being more diligent in assessing patients' needs for statin therapy, by doing this, we may be able to slow the onslaught of MASLD. This is another study that was presented at the liver meeting last year that isn't related to dyslipidemia per se, but ties into the interplay between management of systemic and metabolic disease with steatotic liver disease. This abstract looked at the use of aspirin in patients with MASLD. It looked at 18 to 70-year-old patients with non-cirrhotic MASLD and assessed the impact of low-dose aspirin on intrahepatic lipid content, which was assessed by MRI after 6 months of treatment. It found a significant reduction in hepatic steatosis in all secondary endpoints, including T1 score, which has been demonstrated as a modality at detecting changes in inflammation and fibrosis. And it's also worth noting that there was not any significant change in weight between the groups. Other studies have demonstrated that aspirin is associated with reduced risk of liver cancer in patients with MASLD, as well as reduced risk for fibrosis progression. I found this interesting as we often comment on anti-hyperglycemic medications and statins in our high liver disease population. However, aspirin is not something that I typically make a point of commenting on, or at least I didn't in the past. So there's a link between hypoxia and multiple metabolic derangements in the liver, as listed on this slide, and OSA has been associated with obesity and many metabolic diseases, including hypertension in particular. There was data suggesting that poorly controlled sleep apnea can be a barrier to weight loss and also it's also associated with more advanced forms of MASLD. Thus, it's important to assess MASLD patients for sleep apnea and to make sure that patients are adhering to treatment and it's being optimally controlled. Now let's talk about the future of MASLD management. The primary objective of future treatments for MASLD is to address hepatitis, hepatic fibrosis, and reduce cardiometabolic disease. In the early stages of MASLD, medications targeting metabolic issues may be more critical. However, as the disease progresses to advanced inflammation and fibrosis, liver-specific treatments become more crucial. Recent studies have identified MASH with significant fibrosis, or labeled as at-risk MASH, as a predictor of future liver-related events, making it the primary inclusion criteria for phase 3 randomized controlled trials. For MASH, the US FDA stated that for conditional approval, at least one of the following histologic endpoints should be reached. 1, resolution of NASH without worsening of fibrosis, or 2, improvement in fibrosis by 1 stage or more without worsening of NASH. The European equivalent has much more stringent requirements, demanding both NASH resolution and fibrosis improvement. Full approval of therapies will require demonstration of long-term benefits, including reduction in liver-related events and mortality. Many drugs in the MASLD or MASH pipeline have faced challenges. Some, like obeticholic acid, have failed to obtain approval. Others, primarily used as monotherapy, showed minimal benefits, and many are now being investigated as components of combination therapies. Despite these setbacks in recent years, numerous drugs remain under investigation, offering hope for future options. This slide illustrates some of the drug targets and the pathophysiology of MASLD. Improved non-invasive diagnostic tools are expected to play a critical role in patient selection and treatment monitoring in the future. The development of these new drugs will likely change how we practice and how we manage these patients with MASLD, and really encourages early diagnosis and intervention. And so here's the hot topic. So the approval of Madrigal's Pharmaceuticals Rezdiffra or resmetirom by the FDA in March of 2024 marks a significant milestone as the first drug specifically approved for MASH treatment. However, it's not yet approved in Canada. Resmetirom is an oral, once-daily, liver-targeted thyroid hormone beta receptor selective agonist. Thyroid hormones exert their effect through activation of thyroid hormone receptors located in the cell nucleus. There are two different types, the alpha and beta units, with different tissue expression. The beta receptor are highly expressed in the liver and mediates most of the metabolic effects of thyroid hormone. At the level of the liver, activation of the thyroid receptor leads to reduction in de novo lipogenesis, promotion of fatty acid oxidation, modulating mitophagy and mitochondrial biogenesis, as well as cholesterol metabolism, as well as some anti-inflammatory and anti-fibrotic effects. The Maestro phase 3 trial demonstrated a reduction in hepatic steatosis, as well as MASH resolution and fibrosis improvement as well. It was also noted that there's an improvement in lipid profile with this medication. So interesting to review data from the past year at the upcoming conference to see if and how Canada will be implementing this drug in the future and what inclusion criteria will be given. Fibroblast growth factor 21 or FGF21 analogs have emerged as promising therapeutic candidates for MASLD. It's an endocrine regulator with significant effects on glucose and lipid metabolism, as illustrated in the figure on the right of the slide. Native FGF21 has a very short half-life, but molecular imaging has been performed to inhibit its rapid cleavage and inactivation, allowing for longer half-life. Pegbelfermin was the first molecule, but didn't show improvements in liver fibrosis in the Falcon trials. Efferoxfermin, or EFX, makes it much easier to say, is a long-acting FGF21 analog fused with the FC portion of IgG. And the ongoing Harmony phase 2 trials have demonstrated improvements in hepatic inflammation and fibrosis. PGZ is another drug being evaluated. And it's also been in some phase 2 trials. The Enliven trial, as listed on this slide, showed some benefits. Both are heading into phase 3 programs. And so we'll look to see the results of these studies coming up. And they may also play a role in the future management of MASLD. And Priprenor is a pan-PPAR agonist, activating all three of the PPAR isoforms. It regulates multiple pathways involved in MASLD pathogenesis, addressing lipid metabolism, glucose regulation, inflammation, and fibrosis. It's demonstrated significant reductions in hepatic fat content and liver enzymes, improvements in glucose and lipid metabolism, a reduction in systemic markers of inflammation, as well as improved blood pressure control. It also has potential for NASH resolution and fibrosis improvement. Unfortunately, the Native 3 phase 3 trial was paused earlier this year due to an unexpected serious adverse event in one patient. Was found to have an elevation in liver enzymes. There was question as to whether they had autoimmune hepatitis, but there are plans to eventually restart the trial. So in summary, MASLD is the hepatic manifestation of metabolic dysfunction involving complex interactions amongst genetics, comorbidities, microbiome, and lifestyle factors. The global prevalence is estimated to be over 30%, with increasing rates due to the rising rates of obesity and metabolic disease. It's the most common chronic liver disease and is projected to be the most common cause for liver transplant in the future. Weight loss through diet and exercise remains the cornerstone in the management of MASLD, but it's also important to manage comorbidities associated with metabolic disease and MASLD, to optimize patient outcomes. And there are many existing medications and drugs that we use for metabolic disease, which may have crossover benefits in steatotic liver disease. So I think it's always worth looking for these medications when managing our patients. Individualizing approaches to each patient, considering comorbidities, limitations, barriers in the use of a multidisciplinary team will be important in providing optimal care to these patients. And research is ongoing to identify effective pharmacological therapies and non-invasive biomarkers for diagnosis and monitoring, which could change how we assess and manage patients with MASLD in the future. Thank you, everyone, for attending today's rounds and listening to my presentation. I'm happy to answer any questions now or offline.
Matt, thank you so much for excellent, comprehensive, and evidence-based approach to a huge topic, so thank you very much. It's been amazing, honestly, having the recap of metabolic syndrome and then focusing on the impact on the liver. I appreciate that. So we're open for questions. I think we have enough time to have some discussion. I see Dr. Holbrook hand is up. Anne, go ahead.
Thank you. And thank you, Matt. That was excellent round. So I just have a quick comment and then a question. The comment is around vitamin D. So I just got done in a teaching session yesterday, reiterating that vitamin D has been the panacea vitamin for about 20 years, but it's going the way all the previous have, that when the randomized trials are done, there's no benefit and often some harm. So just some caution around that. I think even in this serious condition, you really need randomized trials to make a recommendation. And the Endocrine Society just in August deleted any screening or lower limit for vitamin D because there's no association with outcomes. My question is around alcohol. So I found it interesting, and you referenced the low risk guidelines, which I fully support. I think that the harms of alcohol have really been underplayed in our society, especially. But I found it kind of paradoxical that in your initial slides around the classification of fatty liver and all of its various seriousness, if I understood correctly, the level of alcohol intake to blame it on alcohol is quite high. Like, I think you said something like 60 grams in men and 50 grams per day. Like, that's 4 to 5 drinks per day. That's quite high. So to me, I wonder if that isn't sort of philosophically, again, underemphasizing the risk of alcohol in this disease. I just wondered what you thought. Thanks.
Yeah, I mean, I always hesitate to tell patients what a safe level is. And usually when they come in and ask me, if what they're drinking is too much, I say, if you're asking the question, then it is probably too much. And it's been classic difficulties with kind of defining what low risk, moderate risk, and high risk drinking is, and putting a number to that. And so I do try to get away from the numbers and the 60 grams. It's very, very hard to calculate that in clinic. That slide early on with the different breakdown and the MetALD kind of diagnosis, I don't do exact calculations. It's a bit of almost a gestalt in terms of where they fall. But I counsel all the patients on their alcohol consumption, and I don't recommend limiting to 6 drinks a week. I always state less is more. If you can't do complete abstinence, then certainly 2 or less drinks per week would be the maximum that I would support.
Thank you, Matt. There's a question about, can you comment on the FIB for score for screening for referral to hepatologists and the role of bariatric surgery? So 2 questions, FIB-4 score, and then does bariatric surgery have a role in the management of MASLD?
Yeah. And so, the non-invasive testing for fibrosis and fatty liver disease is a huge topic, which could be its own rounds. But the FIB-4 is probably one of the original and most widely used scores, and it's the first one that I use. And so I do think that the score is important, especially at the primary care level, to calculate, to determine which patients have a higher risk of having advanced fibrosis and which patients require referral to a specialist for more advanced treatments and care. And so the score of 1.3 is often listed as the threshold. For patients over age 65, the score will be driven up by the age. And so the cutoff now is 2.0 for those individuals. And so I'd recommend calculating these scores for patients when trying to risk stratify and determine who needs specialist care. A word of caution, though, is that a lot of the audience today works in hospital settings. When a patient is acutely ill with elevated liver enzymes, that's not the time that you want to calculate these scores, because that will affect the results. Similarly, if someone comes in with alcohol hepatitis, they're going to have a huge AST to ALT ratio, likely low platelets, and that's going to produce a very high score. So I wait until they come down to baseline before calculating the score and determining their risk of fibrosis. But I do think that this score should be used much more often as in an outpatient setting to risk stratify patients and determine who may need elastography or FibroScan as a second means of assessing fibrosis. In regards to bariatric surgery, there's a lot of good data about the effects of bariatric surgery on or in MASLD. It's very, very good at inducing weight loss, and the weight loss leads to improvements in fibrosis. And so if patients have been unsuccessful with weight loss through different strategies, whether it's dietary, lifestyle, medical interventions, and they're not for surgical candidates, I often send a referral to the bariatric clinic here in town for assessment about their options going forward.
Great, thanks, Matt. That's very, very helpful. There are multiple comments in the chat about how excellent are the rounds, and thank you. I don't see other questions, so I'm going to ask a quick question, hopefully for the last minute, or maybe it's another grand rounds. What about screening? I mean, it looks like prevention is a big piece of it, and metabolic syndrome is common and other manifestations. Do you recommend screening? Is the screening going to come up? What's the cost in the system, specifically for MASLD?
Yeah, I do recommend screening, or at least keeping this diagnosis in mind in our patients with any kind of metabolic disease. If they have diabetes, elevated BMI, lipids, I do recommend getting a liver profile to see if they have any liver enzymes, and in calculating a FIB-4 score or seeking any kind of objective data to reveal the presence of hepatic steatosis. Usually ultrasound is the most appropriate one and the cheapest, most widely accessible. And compared to other common imaging like CT scan, it can pick up lower amounts of steatosis. Ultrasound, it's worth noting, can only detect when there's greater than 20% steatosis, whereas you only need 5% for a diagnosis of MASLD. And so the absence of steatosis on an ultrasound does not eliminate the possibility of fatty liver disease. And so if the shoe fits, then it's still likely. There's newer methods coming out, biomarkers, CAP scores to assess for steatosis, and so hopefully in the future we'll be able to use those in clinical practice to help identify these patients.
Excellent. Great. We're at time. Any more comments to thank you for the rounds and how helpful it's been? It's really great, very comprehensive, great discussion, very important topic. Thank you so much, Matt, and wish everyone a good rest of your day.
Thank you very much, and thanks for having me, and I hope to see you all around the hospitals.